Good evening. This is Dr. John Bennett televising from Miami. We have another in the conference series of the Conference for Pediatric Neurosurgery, collaboration of Neurosurgical TV in the Department of Surgery in the AIMS Hospital, AIIMS Hospital, New Delhi, with headed by not headed, but he's running this. He's the course director, Deepak Gupta. And tonight we have the pleasure of having Sarat Chandra, a neurosurgeon from India, who's going to talk about surgical management of drug-resistant epilepsy. And first we'll introduce the distinguished panel. How you doing, Abdullah?
I'm doing great, thanks, John. Yes, I'd like to introduce myself. I'm Abdullah Reda. I'm an Egyptian student who's studying medicine in Bucharest, Romania. I finished my third year. I'm going to the fourth year. And me, myself, I'm quite interested in neurosurgery. And I'm looking forward to hearing what Dr. Sarat is going to talk about today regarding epilepsy surgery techniques.
Very good. And welcome, Abdullah. Aib, can you hear me, Aib?
Yeah, thank you. Thank you very much for this.
Okay.
So once again, thank you for giving me this opportunity. I hope my audio is clear for you.
Yes, we can see it well.
Oh, perfect. So yeah, as you know, epilepsy surgery, especially the techniques and the recent advances, is a very huge topic. And I will try to see how well I can cover so that I can give a full flavor of what is the most basic stuff, or what is the stuff which we know till date, and what is the more exciting stuff that is coming up in the near future, and where are we headed generally in this direction, and how our own experience goes in this direction. I assume that this presentation would be for a mixed audience, both for the students who have, some for the students who have very little knowledge on epilepsy surgery, some who already have sound knowledge of basic and would like to know more about the advanced stuff. Some, I believe, also would be for practitioners who already have very good knowledge of epilepsy surgery and would like to know what more is happening here. And still, there could be another facet of people who would be interested to just recapitulate their knowledge. So you would see that my presentation, hence, is more like an heterogeneous presentation, which would kind of try to take care of all the audiences who would be accessing it now or even later through the YouTube. So we come back to the fundamental question of what is epilepsy surgery. So we have to understand that the most important thing when we say epilepsy surgery means we are performing surgery in a patient in order to make him seizure-free or epilepsy-free. By the word epilepsy, we mean strike, which means the person is amenable to have seizures again and again. So as all of you know, seizures is not same as epilepsy. So anybody can have seizure as one episode. So you have an alcohol binge, you don't eat, you can have one seizure. You watch a movie whole night, or you don't eat properly, you are dehydrated, you could have one seizure. So this doesn't mean epilepsy. But for some reason, if the brain becomes susceptible so that it keeps on throwing seizures again and again, it is called as epilepsy. And in about approximately 1/4 of these cases, epilepsies are drug resistant, and when we perform surgery in order to stop the drug resistant epilepsy, that is what we call it as epilepsy surgery. So it's very important for us to understand that the primary aim of surgery is to treat epilepsy and not any underlying pathology of the brain. For instance, if the patient has a brain tumor, the brain tumor treatment would be secondary, but the primary goal is to actually treat the epilepsy. Now, it's also important to understand that we don't call the surgery as epilepsy surgery when we perform surgery for patients who have brain tumors with raised intracranial pressure, or when the patient has a few seizures because of a growing brain tumor. Similarly, if you remove the tumor and the patient is seizure-free, once again, you don't say that this patient has been operated for epilepsy surgery. Similarly, absence of any lesion on an MRI or a CT scan does not rule out any surgical cause for epilepsy. I believe the burden of epilepsy surgery globally is very, very significant. So even though we do not have any actual statistics from India because it's a huge country, but if you perform some kind of extrapolative statistics, we find that for every 100 patients, approximately 60 will go ahead to have epilepsy, of which 15 will have chronic drug-resistant epilepsy. So if we extrapolated these figures to the population in our country, we can say at any given point of time, we have about 200,000 candidates who are actually the suitable candidates who can be cured of their drug-resistant epilepsy because of a surgical intervention. So you can understand that the burden of this is indeed quite immense. Now, I acknowledge Professor Gary Mathern for having provided me this slide, and it was also published in Epilepsia, which shows the treatment gap for epilepsy. By the word treatment gap, I mean the difference between what is available and what is actually or ideally required. So in a country like India, if we have to perform approximately 15,000 cases a year if we have to keep up with our caseload of epilepsy surgeries. But currently, at best, we are operating maybe about 500. We have currently at best about 18 tertiary or second level 2 centers, but what we actually require are 600 or more centers. So you can have an idea about the immense treatment gap which exists for this subspecialty. Now this is a paper which has got more than 2,000 citations and is perhaps the most well-quoted paper in the literature by Weeb et al., where using a randomized controlled trial they demonstrated that the surgical arm for drug-resistant epilepsy with mesial temporal sclerosis has a much better outcome than for a similar cohort of patients who have been treated medically. So there is no doubt that the role of surgery is unequivocal. Many people did try to replicate this kind of study, and an ERSA trial by Professor Pete Engel is a remarkable step in that direction. But however, till date, this remains the most quoted study and perhaps the only class 1 evidence which clearly shows that epilepsy surgery is by and large much superior to treat drug-resistant epilepsy as compared to medical treatment. Now, this is one of my favorite slides, especially for neurosurgeons, even though it's been only published in scientific journals, which is meant for neurophysiologists or for neurobiologists. So there is a lot of terms which goes on in literature which says that it talks about epileptogenic zone, it talks about epileptogenic focus, and then some people more recently are talking about epileptogenic networks. So what are all this? So as of the current concepts, people feel that what exists in the brain which creates a seizure network is called as an epileptogenic network. So they are a group of interlinked neurons which may be close to each other, which are usually close to a lesion if a lesion has been detected on MRI, or maybe very far away from each other, but they more or less vibrate in the same frequency and they take part in the same epileptogenic process. And this closely coordinated group of neurons are defined as the epileptogenic networks. Now initially our view of networks used to be more simplistic because we used to think that if you have a lesion in the center, so these group of neurons which actually produce epilepsy surround the epileptogenic, surround the lesion and then they produce epilepsy. But over a period of time we have understood that the neurons which produce epilepsy need not be close to the lesion. In fact, they might be quite well separated and they might be anatomically located in a much far off lesion, a much further off area. Not only that, we have also come to understand that the epileptogenic networks are not static. By static I mean that these lesions, they do not remain constant over a period of time, and they keep on expanding or they keep on becoming more complex over a period of time. Which in essence means that if you have a kid who is 5 years old who has drug-resistant epilepsy, his networks are going to become much more complex and much more difficult to treat after a period of 10 to 15 years if this child does not undergo any form of treatment during this period of time. That is why the whole idea of this is to make the surgeon and the physician to understand that drug resistant in epilepsy is not the same as antibiotic resistance. Drug resistant in epilepsy does not develop with an overuse of multiple anti-epileptic drugs. Drug resistance in epilepsy is de novo. It is because of the neurobiological constitution of that particular patient that this person becomes drug resistant. And if you do not treat this drug resistant as early as possible, these epileptogenic networks are going to expand, they are going to become more complex, they're going to keep on growing, and if you try to treat this patient maybe 10 years later, the outcomes are not going to be as good as they would have been if you have treated this patient 10 years before. So it is very important to understand that once a patient has been diagnosed to have drug-resistant epilepsy, surgery should be offered as early as possible, and there is no point waiting forever or delaying this process forever. Now, it's also important for us to understand that all the pathological spectrums, all the pathological substrates which cause epilepsy are not the same. You could have substrates which I show on the right side, which are something like a good outcome substrates, because usually over here the substrates can be picked up on MRI. The networks are simple. The epilepsy is of shorter duration. It usually generally takes a lower cost of investigation to find the epileptogenic networks and does not usually require invasive EEG. And on the left side you have complex substrates which could be usually negative on MRI, and obviously they have more complex networks. They would have had seizures for a much more longer duration of time, because of which, you know, they would have converted into this kind of substrate from the simple substrate. So there would have been a shift from the right to the left. And generally, to investigate this group of patients, the cost of investigation is very high because they require invasive EEG. So it is very important to understand when we work up a patient with drug-resistant epilepsy to broadly categorize which kind of substrate would he fit into. And this is a very easy, practical method of trying to classify your patients. Does he have a simple network or does he have a complex network? Is a substrate well seen on MRI or is a substrate not seen on MRI? So that itself makes your further decision paradigm very, very easy. Now, many of my students, they often say that they are unable to start an epilepsy surgery program in their department or in their hospital because they do not have all the facilities. I don't think such a argument holds true, or it does hold any water, because if you see, for diagnosing 60% of drug-resistant epilepsy, all you require is a video EEG and a good MRI, at least 1.5 Tesla, and the radiologist knowing how to perform an epilepsy protocol MRI. So if you do this, you'll be able to pick up 60% of the substrates. Yes, you do require more advanced investigations, like a 128 channel dense array electrocorticography or EEG would be useful, SPECT with SysCom and SysCOS facility, PET, and more advanced investigations like a MEG, brain suite, other high frequency oscillation, HFO with EEG source localization, etc. definitely have a much better impact. But all of this combined together help in approximately 10 to 30% of the residual cases, and hence these facilities may be kept at the level 1 centers, whereas the others may be kept at a level 2 centers or at a smaller centers. And in case they are not able to localize the substrate with these two simple tools, then the patient may be further referred to a higher center where he or she may be further investigated to find out the epileptogenic networks. The question also comes, what is the need for us to have all the investigations? After all, for a tumor, we do not require anything more than except an MRI. That's it. We do a contrast MRI and maybe we do some other sequences, and then we are able to reasonably make a diagnosis. But then for epilepsy, why do we need to investigate with so many investigations? The reasons are very clear. You have to understand that each of these investigations occupies a specific camp in the X and the Y axis. where the x-axis stands for the temporal resolution and the y-axis stands for the spatial resolution. Now, you can see the MRI. The MRI is the grossest form of investigation which can pick up time only in the terms of days to months to years, and it can only pick up the grossest form of the brain. Whereas MEG has got a much higher temporal and spatial resolution. Similarly, fMRI, SPECT, PET have various temporal and spatial resolutions. The basic idea of telling this is that for you to understand that epileptogenesis is an event, unlike a tumor which is static, it's always there, whereas epileptogenesis is a dynamic event. It changes over a period of time. And when you want to capture an event, you need something like a video camera, which unfortunately we don't have. Now, falling short of video camera, what we can do is we need different snapshots. So this is what all the investigations they attempt to provide. They attempt to provide different snapshots at different periods of temporal and spatial resolution so that we can understand what is the level of this activity at this particular temporal and spatial event. Now, as per the definition by International League Against Epilepsy, any patient is said to have drug-resistant epilepsy if he has failed a combination of two drugs that has been appropriately chosen and have not caused any side effects and was unable to achieve any seizure freedom. So the word appropriateness is very important because obviously you cannot combine drugs like carbamazepine or phenytoin. That's a horrible combination. Similarly, you have to give appropriate AEDs for appropriate pathologies. So if you do not give appropriate AEDs, then once again the seizures may become worse. So all these factors are very, very important. So that is why the definition of drug-resistant epilepsy is something which an expert, a neurologist or an epileptologist has to make. And he or she has to ensure that these two drugs have been well tried out. It is also very important to rule out pseudo-compliance because most often the patient may not be taking the drugs regularly every day. And in our setup, at least, we find that 30% of the patients actually have pseudo-seizures. So that is why it is essential for us to do a video EEG for all the cases before we take up for surgery. Because in many of the cases with drug-resistant epilepsy, we do come across cases of pseudo-seizures. So they have to be, it's very important that they have to be ruled out. ILE has suggested that we try for at least a period of 2 years, but more recent modifications have said that, including one from a paper which has been published from our own center in 2010, suggests that a much more shorter duration of 1 year is also suffice, because once you establish the patient is drug resistant, he is not compliant with the two drugs, whatever the drugs may be. There could be at least 30 drugs in the market, but if you appropriately choose any two drugs from the market and the patient is not compliant with them, then there is no point trying a third drug, because the chance of third drug leading to seizure freedom is less than 1%. So that is the time you need to work up the patient for drug-resistant epilepsy. Now, we performed this study in our own setup, and this included a large cohort from whole of North India. And we found in our study certain predictors right from beginning by which we are able to predict that this patient is likely to become drug resistant. So one of the important predictors is presence of a structural abnormality. So if a patient has a structural abnormality, one can be very sure that is unlikely to be treated, can be cured medically. Similarly, if the patient does not respond to the first anti-epileptic drug, that is also a very, very high risk factor for the patient to become drug resistant. So one has to keep these two important factors in mind when treating the first seizure. So if you treat a first seizure, for some reason, if you are ending up finding a substrate on an MRI or a structural abnormality on an MRI, with an exception of neurocysticercosis in developing countries like India or in Latin America, which is very common and can be easily treated medically. I'm not talking of neurocysticercosis, but Any other structural abnormality, if it is detected on MRI, or the patient does not adequately respond to the first anti-epileptic drug, then one can be almost pretty sure that this patient is likely to develop drug-resistant epilepsy. Now, presence of febrile seizures and age of onset before 14 years of age is also one of the important factors in our study, which are shown may be responsible for development of drug-resistant epilepsy. Now, based on this, we created something called as a Petri tool, and this was based on a cohort of about 500 patients. And using this tool on the OPD itself, the physician is able to make an assessment whether the patient can be actually identify surgical candidates with drug-resistant epilepsy. And this particular tool is useful for countries with resource-limited settings. So one doesn't have to go through all the expensive investigations. You just run them through this screening tool, and you can be very much sure whether the patient will be a surgical candidate for epilepsy surgery or not. So summarizing, approximately 50 to 60% of all approximately 25% of all epilepsies, they become drug resistant. 50 to 60% of all the drug resistant epilepsies, over here resistant epilepsy means drug resistant epilepsy, they become suitable candidates for epilepsy. We apply the rule of 2, which means that if the patient has not responded to two appropriately chosen drugs in their appropriate dosage, then they should be subjected to a full workup for epilepsy surgery. There is no point trying to go on giving the third and fourth drug. You may give them because still the patient is worked up for surgery, but it is not going to produce any long-term cure. The duration of 2 years is no longer the lower limit, is usually not held as a upper limit. Most of the centers prefer to have something like 1 year or so, because the longer you wait, the more harm it causes to the patient. Now in children, the equations are totally very, very different. Now children's brain is very soft, and it is highly susceptible, it is growing, and it can be easily damaged. And most often the seizures are not so clinically manifest as in adults. In fact, the most subtle type of seizures like infantile spasms are hardly noticeable in children, and they can cause severe brain damage and encephalopathy. Hence, in children, the surgical option, if required, should be considered within months, weeks, or even sometimes in days. And one should not, obviously, the rule of 2 does not at all apply for in children. So if the child has something like infantile spasms, multiple seizures type, rapidly decline cognitive therapy, or a surgical substrate like a focal cortical dysplasia or a hemimegalencephaly or an infarct, all these conditions means that the child has a surgical candidate and should be referred for a possible workup for epilepsy surgery. Now, if the MRI is negative, it does not mean that the child still cannot undergo an epilepsy surgery. It means that the child still has to be referred to a higher center for a complete workup. This diagram, again, I have taken it from Professor Gary Mathern, and it's a beautiful diagram, and it shows the brains of children with 2 identical ages, but one having seizures, and you can see how severe impact the seizure has had on this brain, causing because of severe encephalopathy. That is why it is very, very important to treat epilepsy in children as early as possible. The same has been seen in our own experience. We have now an experience of over 2,000 cases of epilepsy surgeries, of which approximately 700 cases are pediatric, and we published 129 of these cases in this paper. And hence, if we have to consider operating kids, they should be operated as early as possible. Now in epilepsy surgery, we have something called as a concordance. By concordance, we mean that we do imaging, structural imaging like an MRI, then we do a functional imaging like it is SPECT and PET, and then we do an video EEG. So one is an electrical, functional, and structural. And we try to see if all these 3 modalities, they agree with each other. So if they agree with each other, then the surgeon feels reasonably certain that the networks are where all these modalities agree upon each other. If they do not agree, then there are other complex paradigms which have to be undertaken. But the most important thing is that since this is a multidisciplinary approach, all these cases have to be discussed in a multidisciplinary conference where you have the neurologist, you have the neuroradiologist, you have people from nuclear medicine, you have the neuropsychologist, and all of them, they discuss and they talk about the patient, and they put the findings together, and then they take a collective decision of what is to be done, because it's equal responsibility for all of them for having the child to get better. Now, summarizing, there are three myths. I know it's taking a long time for me before I reach the surgical techniques, but believe me, surgical techniques are one of the least important things. The most important thing in this presentation is to know when to do surgery, and most important, when not to do surgery. So it's very important to identify who are the groups who would be benefited by surgery and who are the groups who would not be benefited by surgery, and how important it is for the child to undergo surgery, because it can be a birth-changing experience for the child. It's not like a tumor surgery. The child, it's as if the child has taken a rebirth again. So the first myth is that many general practitioners feel that refractory or drug-resistant epilepsy can be identified only in the late in the course of illness. So that is, you give anti-epileptic drugs for 20 years, 30 years, child becomes mentally retarded, he is absolutely useless, you have tried hundreds and tons of drugs, and then you say, yeah, this is the time when we should send the child to the surgeon. No, it's absolutely true. Please do not do that. If you have done that, you have killed the child. You have to understand that if from the beginning itself you can identify whether this child will have drug-resistant epilepsy or not, because drug resistance for epilepsy is not like antibiotic resistance. It does not develop after you give a ton of drugs. It is because of the inherent neurobiological constitution of that particular child. So, presence of lower efficacy of the first drug. Similarly, even if you have chosen two appropriate drugs in their appropriate combination and the seizures are not getting controlled, and it is well known that newer anti-epileptic drugs do not change this equation. They can lessen the seizures for a couple of months, but they will not, once again there is going to be a breakthrough seizures. So in these circumstances, the child has to be started to be worked up early, to be shifted to a center where they can work up for pediatric epilepsy surgery. Now, this is one of the questions which many parents ask me. They say, doctor, it's not a cancer, so at least my child will not die. Why should I undergo a large brain surgery? Why should I undergo an open surgery? But the fact is, epilepsy kills. Even the risk is very less, which is 0.5% per year, but it is cumulative, which means if the child has had seizures for about 20 years, the risk of child dying because of epilepsy is 10%. If it's had for 30 years, it's 15%. So it is well known, and most important, repeated attacks of seizures, they will knock down a couple of thousand neurons every time you have a seizure. You know, you have 7 billion neurons in the brain. Every time you have a seizure, maybe a couple of million neurons are permanently knocked off. But if this keeps on happening for months to years, you're going to lose your child, you're going to lose the identification with your child as you identify your child to be. And ultimately you end up having somebody who is a complete imbecile or a mental retard, or someone who has to be taken care of, who is completely incontinent, who is bedridden. So you have lost that window of opportunity where you could have treated this patient. Now, surgery definitely is not the last resort. It has to be referred as early as possible. It has been shown world over. Even in our center, even in centers across India, including ours, we have demonstrated excellent results at par or even better than many centers across the world. And hence, if there is an option that a child has to undergo epilepsy surgery, this option has to be given to him or her. So who should be referred? So obviously any child who has a lesion, any child who does not respond to the first anti-epileptic drug, any child who does not respond to any number of anti-epileptic drugs, any child with a seizure disorder with a rapidly declining cognitive disorder are all the fit candidates who should be immediately referred to a neurologist who is an expert in dealing with pediatric epilepsies, because all of them may be harboring lesions or networks which are potentially amenable for surgical treatment. Now this is some recommendations which we have published, level 1 and level 2 centers. So level 2 is higher centers. My apologies, earlier I was quoting the reverse. And level 1 is the lower centers. And it's important for us to have a tiered approach. Otherwise, it would be very difficult for a level 2 center to handle all kinds of cases. And this is the kind of protocol we have for doing an epilepsy MRI imaging. And you can see it's got many parameters which are very straightforward. It's only important that the radiologist sensitizes himself or herself how to do these sequences in every patient. And believe me, with this, you can end up detecting many subtle cases. Ictal SPECT with SysCom and SysCos is also very useful for detecting focuses. We usually do positron emission tomography in cases which is completely substrate negative or MRI negative, in which cases they are useful for us to detect subtle pathologies which are not detectable on MRIs. Now I apologize for this crowded paradigm of management what I have drawn here, but as I explained to you, you will understand that it is not so difficult to understand. So on the top we have a child with a drug-resistant epilepsy. So the first and most important step is to understand whether the MRI is positive or negative. So if the MRI is negative, then we would still recommend that he undergoes a repeat MRI as per epilepsy protocol. And surprisingly, even 60% of the cases they become positive. In 40% of the cases they may be still negative. So now whether they are positive or negative, they go to the next step, which is the video EEG. So these two steps are, they are non-compromisable, they are non-interchangeable, and they are constant. So you have first an MRI and then you have a video EEG. Interictal EEG, of course, is always done in cases of patients who come with seizure semiology. Just to show an example, this is an MRI which is negative. But when we do a second pass MRI where I have shown the red arrow, suddenly you end up picking up all the subtle changes which have been picked up on MRI. All these patients were referred with normal MRIs to our areas, to our center, and when we did an epilepsy protocol MRI, we ended up detecting subtle lesions, and it is very important for these patients because then they were being able to take up for surgery and they had very good outcomes. So this is a scenario which happens in approximately 40% of the cases. Now in 60% of the cases, what happens is the MRI is negative, but when you do a more advanced investigations like a PET MRI fusion, you find that, for instance, over here the whole of temporal lobe is hypometabolic. And when you go back, then suddenly you end up detecting a subtle lesion on the MRI. So in 20% of the cases, you do a more advanced investigation, and then you go back and you are able to find out that this you have been able to actually detect a lesion retrospectively. Now the fMRI, now the in our center we have never used WADA for two reasons. Firstly, sodium amytal was never easily available in our center, or anywhere in India for that matter. And secondly, most of our intervention radiologists are too busy to do ODA. But however, we developed our own protocol for fMRI, which has been very effective, and we have been using this for the past 15 years or so, and we have patented the same thing in Hindi. So we have patented the whole software in Hindi, and we are able to generate all kinds of functions, including word generation, syntax generation, comprehension tasks, semantic memory tasks, right? Of course, motor is a standard which anybody can do. And this is the kind of paradigms which we have. And just to show that over a period of time, we have developed so much of confidence in our fMRI. For instance, over here, this patient had a lesion in the anterior part of the occipital lobe. So obviously, we were hesitating to go inter-occipital because we can risk of damage to bilateral visual fields. This is on the left side. But when we did an fMRI, we found that the entire language has been shifted either anteriorly or it has been shifted to the opposite side. So we did a surgical approach through the traditional conventional Wernicke's area, and then we took out the lesion, and patient was absolutely intact. So in our experience, we have validated this in over 1,000 cases, and we have found fMRI to be very, very reliable, and it is non-invasive, and we find it very, very convenient to do it in all our patients as a part of pre-operative assessment. Now we come to the second part of this paradigm, where we think of doing more advanced imaging like a magnetoencephalography or a PET or a SPECT. Now, a lot of things have been written about PET and SPECT, but our question was that what is the utility of combining both of them? If we combine both PET and SPECT, does it help in predicting a better outcome for the patients? Because such a study has not been published in literature earlier. And we did that. We published the study, and we found that whenever the PET had a concordance with the SPECT, it predicted a good outcome for extratemporal surgeries with a significant p-value, but it did not improve the outcome for temporal lobe surgeries. We also have magnetoencephalography, which is part of a research project, which is the only one of its kind of machine in the whole of North India, and only one of its kind in the world, I think, where it is completely done free of cost because it's a research tool, and we have done close to 1,000 cases till now. And basically speaking about the magnetoencephalography, what we have is we have an array of squids which are called as superconducting quantum interfaces devices, which is placed cooled in helium all around. And what MEG does is it basically ends up detecting signals which are 100 million times less than the Earth's magnetic field. So if you have the Earth's magnetic field here, and this is what are the MEG signals. And in order to do that, the patient is to be kept in a magnetically shielded room, so that all the external magnetic interference, like from the power lines or from the moving vehicles, can all be avoided. So it's an extensive procedure. It takes almost 3 to 4 hours per patient. So you initially have a digitization where you put all the electrodes, you put the cap, and this is how the signal shows up. So initially it shows up like a cluster of dipoles, but more recently we've been using the Curry software, and where we have been able to pick up more focal signals. And more recently we have been using more advanced methodology by which we have been able to actually demonstrate the propagation of the epileptogenic signal. Just to show a few examples, the lesion here, 23-year-old male, 6 to 7 episodes per week. The fMRI doesn't show any activity over the lesion. And when we did the MEG with accelerata, we confirmed that this is actually confirmed. There is a focus right on the spot where we see a lesion on the MRI. And at the time of surgery, we find that the maximum electrocorticographic activity was from the same area, which was MEG positive and which was also MRI positive. So obviously this gives a great deal of confidence for the surgeon, and once we resect it, Electrocorticographically, we get a normal recording all over and the patient is seizure free. Similarly, we have found that MEG is very useful in deciding which lesion to remove, particularly in multiple lesions like tuberous sclerosis. I have a paper of this in epilepsy. Excuse me. Now, electrocorticography is a technique by which the electrical activity can be measured directly from the brain by placing an electrode on the surface of the brain. It's a very age-old technique which has been done right from the time of Penfield. And there is, even though there is not much of class 1 evidence, but most of the surgeons do it. Many more surgeons also love to criticize it, and many more surgeons also have given away to invasive EEG. But then for a developing country like India, it was important to revive this technique because many of our patients, in fact, most of our patients cannot afford to undergo invasive EEG. So we have to actually innovate our own techniques so that we can make the surgical techniques not only surgically effective but also cost effective. So we have done a few modifications. First is we have given a scoring system for each electrocorticography, and this score we have borrowed from the one which has been published by Cook and Mathern. And we do pre-op recordings as well as post-op recordings. Our anesthesia parameters are also kept very, very accurately, and we have published over 2 papers on this. And then this is just to show, for instance, 27-year-old male, 7 to 10 seizures a day, neurocysticercosis, severe edema. So we place an electrocorticographic grid, we remove it, and finally you can see amount of brain which was removed was quite significant because it was a grade 5 electrocorticographic activity. So these are some of the papers which we published. We have now more than 1500 cases of experience with ECOG, and we also published, this is a paper which has been published in Epilepsy Research, and we also published our anesthesia parameters. And the grading system we have is 1 is normal, 2 depending on the existing situation, and 3 to 5 is considered abnormal depending upon from which area it is coming from or what is the underlying pathology. But we always do post-op recordings because it gives us a very good feedback and a reasonable sense of confidence about the degree of resection. For instance, we have a lesion here. It shows a grade 5, the worst kind of ECOG score when we put electrocorticographic grid. So when we partly remove it till the level of the blue line, we find that it normalizes to score 2. But when we resect it till the level of this light blue line, then we find that the score normalizes. So at this point, the surgeon gets a good degree of confidence that the resection has been optimal. Now, there will be situations where despite all your hypotheses, all your pre-op investigations and every kind of investigation done, we will not be able to reach to an hypothesis, in which case an invasive EEG will be required. So over there we will have to introduce electrodes and then monitor the patient. So the main indications for such condition for invasive EEG is presence of substrate negative epilepsy with a reasonable hypothesis. So it has to be a hypothesis driven. Now the strategy we nowadays we have practically stopped using depths and grids. We only use stereoencephalographic leads. And unlike many other centers from the West, what we do is we first create a very strong hypothesis as much as possible using all possible pre-operative non-invasive investigations. So we do a full workup which includes a video EEG, which includes an HFO, which includes a magnetoencephalography, PET, SPECT, and using this we also do a multimodal imaging. Then we try to create the best possible hypothesis. We go through the MRI images again, especially through the flare sequences, trying to see if there is any subtle cortical dysplasias, and then we try to create a hypothesis by which we can try to place as few SEEG leads as possible. And based on that, we try to create an hypothesis for the network and go ahead and do the surgery. Similarly, for lesions located over eloquent cortex, for mapping eloquent cortex, or for multiple lesions, for discordant preoperative investigations, these are some of the generalized investigations, indications for invasive EEG. Just to show an example, 23-year-old male, 3 to 4 episodes per day, most of the episodes happening at night. The patient was a child, now is a male, underwent 6 to 7 MRIs over the period of 10 years. All of them reported normal. You can say this MRI is normal, PET MRI fusion is normal. Now when we did a MEG, we got a very strong dipole in the left basifrontal area. Now fMRI once again shows localization away from this area. So summarizing, what do we have? Now ictal spect shows activity from the top, from the vertex area. So summarizing, what do we have? We have MRI which shows normal, but on close examination, based on the MEG analogy, we find query there could be some cortical dysplasia in the cingulate or in the insular basifrontal area. The video EEGs typically suggestive of a frontal epidemiology. The fMRI shows activity well away from the areas where we plan to do resection. The PET is once again not indicative of anything. Ictal spect is basically on the top of the frontal, once again not coordinating well with the MEG. And the MEG is what kind of correlated to some extent with the video EEG. And when we re-examined the MRI over the thin sections on flare sequence by changing the windows, we could see perhaps there may be some areas of cortical dysplasia. We don't know, but that is only on very much on a retrospective analysis. So what did we do? What should we do? Obviously, you cannot go and resect in this case. So what we did is we did stereoencephalographic implantation of electrodes. So we have this robotic device called a ROSA, which is very convenient for us to point out to the area where we need to put an electrode. So once that is done, we make a small twist and then finally we inject, we put in the electrode, which is the stereoencephalographic electrode. So this is how the leads looked like. So ultimately we ended up putting 7 electrodes. So 4 on the left side, because most of the focus was on the left side, and 3 on the right side. And then we were quite pleasantly surprised that on 4th day, when the patient had a seizure, we found that it was the left basifrontal which started to spike, and it spread to the left insular area. So by this we were clearly able to get an epileptogenic focus. So I went ahead and we did a left frontal resection along with the insular resection as well as a basal opercular resection. And it is a much more extensive resection than a frontal lobectomy. Now patient had an initial weakness of about 4/5, which was more like an apraxia, which is very common with this kind of resections. But over a period of time, it improved very rapidly, and currently he is seizure free. So this goes to show that if you create a very good hypothesis and you know exactly where to put the leads, you can minimize the number of leads you need to put, and you can also improve the patient's outcome rather than go on putting leads everywhere, and then you would lose focus. You wouldn't exactly know how to interpret your results. Now this is another interesting case which I thought I would like to show to you. A patient having about 5 to 6 seizures per week till now, and about 3 years ago underwent excision of a neurocysticercal cyst in the anterior part of the occipital lobe, because that is what was seen. But in terms of seizure semiology, it was not occipital at all. It was more like a temporal. But when we examined the MRI, the temporal lobe was completely normal, including the MRI, PET MRI fusion. And you can see that the MEG shows a very good activity in the left temporal area, and it is correlating well with ictal spect. So functionally there is something in the left temporal, but anatomically the left temporal is normal. So what do we do? So obviously it's another case for invasive, but how many electrodes? Do we just go and puncture in some 20 or 30 electrodes and then try to see what's happening? No, we did not. What we did is we just put 2 electrodes, one within the hippocampus and one just around that pericyst area in the occipital area. And with this, we were beautifully able to demonstrate that the seizure generation is actually arising from the temporal, and the occipital lobe is completely quiescent. So we went ahead and performed a left temporal lobectomy, after which the patient became seizure-free. So we have already gone through a number of surgeries during the course of presentation, but I will quickly show you the principles of other types of surgeries which are there, because I have something like 3 minutes left. So basically surgery could be resective or it could be disconnective. So by resective we mean that we remove a part of the brain completely, whereas disconnective is we disconnect that area from rest of the brain. And these are the various types of surgeries. So basically they could be divided into a curative surgery as well as a palliative surgeries, and that is a more functional and a more practical way of trying to classify the surgeries. Now the temporal lobectomy is the commonest type of surgeries done and which has been described by Wilder Penfield for the first time. And these are the host of structures which have to be removed. So one has to understand that it's not just amygdala and hippocampus which is to be removed, but also the parahippocampus, the cerebellum, the anterior part of ventrorhinal cortex, the uncus. So all the structures have to be removed because you are removing a network, you're not removing a focus. Now world over meta-analysis has shown that a traditional classical anterior temporal lobectomy with amygdala hippocampectomy has a better outcome than a selective amygdala hippocampectomy. Just to show an example, one of our cases, this is the post-op, and it's important that in the post-op the hippocampus has to be resected till the level of superior colliculus. Now there are other forms of surgery called as disconnective surgery. For instance, the child has a porencephalic cyst with a strong focus of MEG from this area. So we make incision like this and we disconnect we do a TPO disconnection. So another example of a Sturge-Weber syndrome, and this is post-op image where a TPO disconnection or the temporal, parietal and occipital lobe is disconnected from rest of the brain. Now there is another form of surgery which is actually very effective, even though it is very, very dramatic and it's very, very major surgery. It's hemispherotomy. We did our first hemispherotomy in the year 2002 in this child, and you can see one of the incisors of this child is missing because this child came with about 400 seizures a day and was intubated unconscious, and we thought we were going to lose the child, and this is the child today. When we did the hemispherotomy, so this is like a rebirth surgery, and since then we have done over 70 cases of such hemispherotomy techniques. And we published the first series of hemispherotomy from this country. And the most important indications for hemispherotomy is any kind of hemispheric pathologies. And more recently, we established an endoscopic technique for performing this kind of surgeries, where the whole surgery can be performed through a very small incision. And you can see this is the pre-op and this is the post-op disconnection. So corpus callosotomy is a palliative surgery which is done for drop attacks, and recently it is most responsive surgery where the patient has drop attacks, especially for a syndrome called as Lennox-Gastaut syndrome. And more recently we also described an endoscopic technique for doing corpus callosotomy, and the outcome of endoscopic corpus callosotomy with commissurotomy has been found to be superior to that of traditional corpus callosotomy. So I will stop here because my time is over. I thought I could show you some more of the advanced stuff, but
you can do that. Yeah, you can do that.
I can continue for some time.
A little bit. It'll be back. Will just be a couple minutes, right?
Yeah,
So,
I'm already there. So
Yeah, just a couple of minutes. So sure. Go,
yeah, no
continue.
problem, sir.
Continue.
There is no problem.
Continue.
Yeah.
no problem for me to continue.
Yes.
So for how long can I continue? If you can give me a time frame, I'll finish it off before that.
Well, how much time are you going to take, do you think?
About 10 minutes more if you want me to do it comfortably.
Well, it's up to Vivek. It's up to Vivek.
I have no problem, sir. Please continue.
Okay, go ahead. Very good. Thank you, Vivek.
Yeah.
Okay. So, so now in the palliative stuff, you have something called as vagal nerve stimulation, which is one of the commonest surgical techniques which is performed in the West. Now, you have to understand that vagal nerve stimulation is more like a drug. So it does exactly what a new drug will do. It will reduce, it is effective in 50% of the cases and reduces the seizures by about 50%. Now, it is not a magic formula because most of the people, especially from undeveloped countries, thinks that it is like a cardiac pacemaker. So rather than doing a surgery, you put a pacemaker and you are going to be free of seizures. So as surgeons, it's very important for us to be responsibly speaking to the patients about this technique and telling what could be the shortcomings. Now in our center we have done about 6 cases of vagal nerve stimulators, but most often we prefer to do a corpus callosotomy with commissurotomy because of the fact that many of our patients are not very well to do, and also because of the fact that we deal with very severe pathologies of Lennox-Gastaut drop attacks. We found that doing corpus callosotomy with commissurotomy is actually very, very effective for such pathologies. Now, the other modalities which has kind of drawn interest over the past decade or so has been the neuromodulation, especially using DBS. Now, the most popular trial which has been done is a Santis trial, which has shown that it is more or less as effective as DBS. It's as effective as VNS, that is vagal nerve stimulation, which brings to the fact that if VNS is more safer because it's an extracranial device, why should we use a DBS? Now, our experience with DBS has been limited. It's for 3 cases. So basically what we do is we put the leads into the anterior thalamic nucleus, and that's the kind of recordings which we get from the anterior thalamic nucleus. And over here we put leads, we put the electrical leads all over the brain, and then we produced 2 types of rhythms. So basically it is an EEG driven surgery. Unlike Parkinson, which is an MER driven surgery, you drive the surgery based on your microelectrode recordings. DBS for epilepsy is driven by what findings you find on the EEG. So initially at a lower frequency of 2 to 10 hertz, you produce something called driving free rhythm. Now as you increase the frequency to about 100 to 150, and in our experience, on my personal communication with Arthur Kukert, who has got a large experience from Latin America, we've even increased the frequency to about 200 to 300 hertz, and we find that that actually works out better. And we are able to completely desynchronize the EEG, which means that at this point, the DBS is going to be effective for epilepsy, and that is the end point where it should be programmed. And that's one of the patients with with the VNS where we have done, who is undergoing programming. Now, laser ablation is another exciting modality, which we did in few cases, 3 cases as a part of a workshop, because this device is not currently available in India, but we did it as a part of workshop, courtesy Professor Ashwini Sharan from Thomas Jefferson, in collaboration with Medtronics, who are very kind enough to get this completely free of cost here. Now, this is a really exciting tool because it comes out with a very thin lead, which has also got a self-cooling system around it. So the kind of lesions it produces are really microscopic with very minimal damage to the surrounding areas. So the entire lesion is actually MRI guided. I'm sorry you can't see the video here, but it plays on the slide mode. But you can actually see the lesion which is produced on the MRI, and you can be very sure that the surrounding areas are completely saved. So during a workshop when we performed, that's Professor Ashwini Sharan here and the entire team from Medtronic, and that's Michael Kang, his student, and that's a child who had hypothalamic hamartoma, who just had one stitch surgery, who underwent laser ablation for hypothalamic hamartoma just half an hour after the surgery. So one can appreciate how minimally invasive this procedure can be. So we do have really exciting days ahead with this kind of technology coming up. So now let us summarize. So is epilepsy surgery worth it? Definitely it's worth it. We have an experience of over 2,000 cases. It's a rebirth for the patient. You are actually giving a new birth to the patient. You're not curing the patient. You treat a patient, he or she is seizure free, comes back, they has joined back to the work, the whole family is happy. If it is a girl, she finds a job, she gets married. There are no words of gratitude that they can express to you. You treat a malignant tumor with all due respects. I mean, every pathology has to be treated with respect. But all these pathologies, they have a limited life cycle. But for epilepsy, if you treat an epilepsy, it is a rebirth. The whole life changes for this patient. Overall results have shown that it is best for mesial temporal sclerosis, which is in the range of 80 to 85%. It may reduce to 50 to 60% over 25 years as shown by Cleveland Clinic. But one has to remember that there are many surgical nuances which may actually modify the outcome. For instance, one of the most important factor is the amount of hippocampus which is removed. Many surgeons just nibble and remove a small portion of hippocampus. That is to be discouraged. You have to remove the hippocampus till the level of superior colliculus, and that itself, enhances the outcome to a great extent. And this finding has been demonstrated by no other than by a neurologist who was working with Professor Yasargal and with Professor Yasargal's own cases. So when they followed up, when they did an MRI, they found that his cases, they did well whenever the hippocampus was resected up to the level of superior colliculus. So other cases, temporal resection 75 to 80, extratemporal 60 to 70, hemispherotomy is very high, sometimes could be 100%. Corpus callosotomy is a palliative 30%, but remember that you are doing corpus callosotomy in a subset of patients who are so sick. They are having hundreds of drop attacks, they are injuring themselves, the parents are in misery, the child has to wear a helmet, and moment the drop attacks stop, the quality of life of the parents improve. So just by the fact I say that it's 30%, the figure looks 30% over here, grossly underrates the improvement or the effect or the quality of life it may have on the patient. Multiple subpile transactions again is a palliative procedure, is not very effective. Vagal nerve stimulation has to be considered like a new drug. But if you see all these figures, these are way ahead than less than 1% of improvement that these patients would have had if they would have been given just medical treatment. Now, in our study, we have shown that once seizures stop, the memory and intelligence also improves, provided the damage is not very severe, and most of the milestones of the children will recover back. Certain seizure types, even though may not seem clinically severe, but produces severe brain damage if it is not controlled, example, infantile spasms. Thus, even if sometimes large portions of the brains are resected in epilepsy surgery, cognition is not usually impaired. Control of epilepsy seems to be the bottom line for cognitive and quality of life improvement. So this is a center of excellence for epilepsy, the first of its kind of India and maybe Southeast Asia, where we have a comprehensive clinical research and an investigative center. We have a magnetoencephalography, we have a robotic device, we have a full-fledged OT, we have a advanced molecular and cellular lab where we can do a single neuronal recording, we have research faculty, we have dedicated surgeons and dedicated neurologists, and the whole idea of creating such a focused center is that because it is a multi-speciality disorder, so it is important for all the people from various multi-specialities to sit down, think together, and feel together for this really difficult but very gratifying disease. So these are the few papers which have come out from our COE lab, which has been published in high impact journals like Genomics, where we are studying on epileptogenic networks. And finally, just a few days away, I would like to invite, if anybody is watching this, to our second AIMS NBRC DBT Epilepsy Surgery Neurobiology Workshop, where we are having two renowned faculty. One is Dr. Christopher Skidmore and Dr. Chengguan Wu, both from Thomas Jefferson, where we will have a cadaveric course on day 1, followed by live surgeries on day 2 and 3. And the registration, I would say, is the cheapest in the world. It's 2,000 Indian rupees, which would be something like, just a few dollars. That's it. So for those of you who would be watching this video, who can come to India or are in India, they're most welcome to come and attend this workshop. So thank you very much for this opportunity again, and it's been wonderful giving this lecture, and I hope it has been fruitful and useful to all of you who have listened to this. Thank you very much.
Yeah, yes, Sarat, yeah, it certainly is fruitful and useful. Very comprehensive. You did a lot of work there, a lot of hard work, a lot of research, a lot of putting together that presentation. I'm sure that anyone in the field would love to hear that. I hope a lot of people do. I just have one quick question. Vivek's waiting, so we won't take too much time. You don't even consider surgery for an epileptic that is responsive to medication, or it's only for people that don't respond?
Yes, you have asked a very pertinent question, and I'm so glad you asked. Epilepsy is primarily a medical disease treated by medicines. 75% of all epilepsies are treated with medicines. 25% of all epilepsies, they have something called as a drug-resistant epilepsy, that is, they no more respond to the drugs. So these drug-resistant epilepsies are the candidates who may become the candidates for epilepsy surgery. Okay. Not all the cases with epilepsy. So right. On my entire lecture, I have shown some methods by which we can identify these patients who have drug-resistant epilepsy. Okay. Now, the second part of the question answer is that these drug-resistant epilepsy, you can identify them very early in the course of disease. So please do not be under the misunderstanding that you have to treat a patient for 20 years before you say that this patient is drug-resistant. So if a patient with epilepsy does not respond to the first drug, that is a first warning sign that this patient may have drug-resistant epilepsy. If it doesn't respond to the second drug, you are confirmed that you are dealing with a drug-resistant epilepsy. So even if you are having 30 drugs in the market, this patient has to be worked up or sent to a higher center and has to be looked into more options of treating his condition.
Okay, very good.
Am I clear, John, about this?
Yes, thank you. Now, Abdullah, do you have any comments or questions?
Yeah, sure.
Yeah, I'm glad you asked that, because sometimes you speak so much of complex stuff that you sometimes leave some doubts for the most basic stuff.
Yes. Okay, Abdullah?
Yes, sure. First of all, I'd like to thank you for the great presentation, great work.
Thank you.
Second, I have just a quick question. The part that you mentioned about the hippocampus being resected, doesn't that have any implications on the cognitive functions of the patients afterwards?
Yes. See, patients with epilepsy, when you operate them, the cognitive functions actually improve over a period of time. That's the ballpark finding which is found all over the world, but with various caveats. Various caveats means there are certain aspects of functionalities which may be affected after surgery. There are certain other aspects which are not affected. But if you see the overall functioning, overall intelligence, all these things, they improve much better after the surgery is done. And the analogy is very simple, because the brain has something called as plastic. I'm sorry if I speak it in a very basic manner, but assume that a lot of people who listen to this would, would be basic undergraduate students, or they may be even non-doctors. But brain has something called as plasticity, whereby if that portion of the brain becomes abnormal, so these functions are automatically transferred to other areas of the brain. So at this point, if you remove this area of the brain, the overall functionality is actually going to improve. The analogy is very same, like you are running, let us say John is running this neurosurgery television with 10 people. So there is this one guy who is, he has delegated responsibility equally to this 10 people. And then there is this one guy who doesn't do work anymore, and he is just coming late, going off early, doesn't tell where he goes, and then after some time, he is making things uncomfortable for John. He doesn't do any work. So at the first stage, John will, shift his responsibilities to the 9 other people. But then this fellow continues to be a nuisance. He still won't work. He will actually stop others from working. Then in fit of desperation, John will dismiss this, will fire this guy. And then you will find that even with 9 people, the overall efficiency has improved. Am I right, John?
Yes.
In saying this?
No, yeah.
So the brain functions exactly in the same way. So even the number of neurons in this brain are constant, but if there are a couple of neurons which go bad, or they do only things which are causing damage to the body, like producing seizures, the functions of these neurons are now transferred to the rest of the neurons. So at this point, even if you remove these neurons, over a period of time, the effect you're going to have is only a good effect. So your many functions are actually going to improve.
Very good. Okay, we'll wrap it up. Thank you very much,
Thank you.
Sarat. Can you get off the Hangout there? Just get off the screen share. So I don't think anyone's seen your face during the presentation. Okay. Just click on that green arrow on the far left. Far left. Okay, very good. Thank you very much, and we'll see you in an hour.
Thank you.
You're welcome to stay. We're going to finish this. We'll start the next one. Thank you. Thank you very much.